Our next presentation is by Dr. Adam Gleason, and Adam was mentored by Dr. Avni Chabra, and the title of Adam's presentation is 3D CT Segmentation of CAM Type Femoroacetabular Impingement, Reliability and Relationship of CAM Lesion with Anthropomorphic Features. Speak to us.
Thanks so much, Dr. Morris. My name is Adam Gleason. I'm a second-year radiology resident here at UTSW, and today I'll be talking about 3D CT segmentation of CAM lesions and femoroacetabular impingement. I'd like to thank everybody involved with the project. Let's see how I click forward here. Okay, so we looked at doing volumetric measurements in FAI rather than what's been established, which is more alpha angle measurements. And so we'll kind of go through what these different kind of measurements are and what this project holds for the future of FAI management. So femoroacetabular impingement, it is a bony abnormality of the hip joint. It comes in a couple different flavors, but basically this bony overgrowth causes cartilage and labral injury during hip motion. And so there's three different types. There's the, how does this work? Okay, whatever. There's the pincer type, which is bony overgrowth of the acetabulum, and this basically crushes the labrum underneath it during hip movement. And then there's the CAM type, where there's a bump that forms at the femoral head-neck junction, and then while the hip moves, it kind of grinds the cartilage underneath it. And then there's the combined type, where there's just, it's a bit of both. So as far as femoroacetabular impingement, these patients present to the sports orthopedist, usually with groin pain and stiffness that's exacerbated by certain movements. The orthopedist then takes a clinical history and then does a targeted physical exam with certain movements to kind of further see if they agree with the diagnosis of FAI, at which point they obtain basic imaging, usually hip radiographs, where they do alpha angle measurements and kind of see if this is all in line. Next, once they're pretty sure they're going to go on to surgical correction of this, then they'll order more high-grade imaging, such as 3D CT of the pelvis and MR of the pelvis, and this is kind of more for preoperative planning. They can see these bony overgrowths as well as they can assess for cartilage and labral injury. And as far as the actual treatment goes, it's femoroplasty. They basically grind down the parts of bone that are the problem and then fix the cartilage and labral injury that's while they're in there. So as far as the established measurement for this, it's alpha angle. Alpha angle is basically a line drawn from the center of the femoral head down through the neck, as well as another line that's drawn from the center of the femoral head to the femoral head-neck junction, and then basically you look at the angle between there. So generally normal is thought to be less than 55 degrees, and abnormal is greater than 55 degrees. And what we're doing here is basically it's an indirect measurement of that femoral bump. So rather than just doing kind of an indirect measurement, what we thought we do is do a volumetric measurement. So basically this bump lesion has a different attenuation to the bone that's surrounding it, so we can just throw a growth ROI on there and basically assess the volume of these CAM lesions as well as assess the volume of the femoral head. So it was our goal to see if doing these volumetric measurements would be a feasible and fast and reliable way to assess for femoroacetabular impingement rather than the established alpha angle measurements. So this is a retrospective IRB-approved study of patients who were diagnosed with femoroacetabular impingement who had undergone 3D CT of the pelvis. And basically, myself and another radiologist went through all of these images and measured the alpha angles as well as measured the volumetric measurements. And then we compared to see how reliable we are in doing these measurements. So the population we started with 58 patients who'd been examined by CT. That we then excluded 9 patients who had had prior surgery to that affected hip joint. And then we excluded an additional 6 who had the isolated pincer type FAI, because in that case there's no CAM lesion to measure by our analysis. So that landed us with a final 43 CAM or mixed type patients. So looking at general demographics, you can see this is a younger patient population with the average patient age in the mid-30s. And additionally, we had a pretty close male to female ratio of near 1 to 1. So then going through the actual timing of doing these measurements, you can see that 3D segmentation is quite a bit faster than doing the alpha angle measurements. It took about 4 minutes, which is about a third of the time. It took about 12 minutes to do the alpha angle measurements. And then as far as the inter-reader variability, we use interclass coefficient to kind of quantify this. The 3D segmentation was excellent for the femoral head and fair to good for the bump, but it was quite poor for for measuring the alpha angles. So as you can see here, the CAM lesions in males is quite a bit larger than in females, as well as they tend to have larger femoral heads. So in kind of discussing this, we found that doing this volumetric measurement of these CAM lesions is feasible and fast and reliable when compared to alpha angles. Anybody who's spent time doing alpha angles, they're pretty tough to do. You have to make sure you get the planes just right. It's pretty cumbersome. So getting the same measurement from yourself over and over again is difficult. And then, between radiologists, there can be some variability. Additionally, if the foot's in the scanner a little bit funny, that can also change the alpha angle measurements. And with this volumetric measurement, we don't run into any of those problems. Drawing the ROI is actually pretty quick and easy to do, and as you can see here, pretty recreatable. Additionally, we found that there is a significant positive correlation between height and the size of the CAM lesion, as well as this stayed true for when we separated out for females for gender. And then finally, we also found that patients who had, and then the male patients have larger CAM lesions than females do. And this could have treatment implications. If they know they've going to have a larger CAM lesion, they might know that they have to do more invasive, more grinding off of that bony prominence in surgery. So as far as limitations go, this is a retrospective study. Additionally, a small majority of the patients here did have a degenerative change, and so that can cause kind of bony overgrowths, which can affect some of these measurements. And additionally, we didn't have any control patients for this study. These were all patients who had been diagnosed with femoroacetabular impingement. So kind of in conclusion, what we did here is we established that this measurement is fast and feasible, and more reliable than alpha angle measurements. So kind of things in the future would be to kind of look at the clinical implications of this measurement tool and see how we're going to be using it in the clinical setting. So thank you so much.
Thank you, Adam, and we have time for questions.
Thank you, Adam. I didn't catch it. I may have missed it. Did you do inter-reader and intra-reader variability?
I believe we just did inter-reader variability. So just looking at...
So something else that's useful is a retest from a given reader, because then you can see how accurate you are and how reproducible one is in doing that. Second question I had in the design, the criteria for entry was a CT. Not everybody gets a CT, so is there some kind of bias that can be present in the types of patients you get because you require CT to get in? I don't know the field well enough. Why does one get a CT and why would one not get a CT?
That's up to the surgeon on how, I believe, how comfortable they are with the diagnosis, as well as their preferences for for planning for the operation. So we kind of only had the ones that they ordered it on. So I'm not sure about the patients that they didn't order it on, how they felt about going in a procedure.
So what do you think the possibility is for automating this so you don't have to draw the ROIs?
Yeah,
do you think there is a possibility of doing that?
Absolutely, yeah. We could either have the software do it itself, or possibly have even a mid-level do it. It's quite easy to do. So yeah, I definitely think in the future that this could be something that could be automated for us.
Yeah, I would like to reply to Dr. Rofsky's question. Getting a CT and MR arthrogram is standard for these patients who have to go surgery. So anybody undergoing or for preoperative planning, they always get a CT. And so all these patients are pre-op patients. It has been shown that if you resect less of a bump, those are the cases who fail, or they may have recurrent tears. So it's important to quantify. And what our orthosurgeon is doing after this research, actually there's another part which hasn't been presented. We correlated these with also, we adjusted for the height and for the gender, and still it was larger with the height. And then secondly, we correlated with the surgical extent of the tear. We had another surgeon come in, look at the op pictures, and regrade all the labral tears. And we measured in terms of clock hours how big the labral tear is. And there was a direct correlation of the extent of the bump with the labral tears. There wasn't a correlation with the cartilage damage. So that paper is also under review. We don't have the controls which we plan to do in future because many patients have asymptomatic bumps. So these are all pre-op. And then for the automated, this is semi-automated. So if you just have to take the bump, it takes less than 4 minutes. You can do it very quickly. And getting automated will be an advance. That can be done on CT, yeah.